Great. Hello, everyone. Welcome to the 2020 Public Health Law Virtual Summit. We have two presentations in this session, and each presentation will be followed by a Q&A. Use the chat feature to submit your question. If you encounter technical difficulties during the summit, go to the navigation menu and select the Need Help button. Now I will turn it over to our first speaker, Katie Moran McCabe.
Hi, everyone. I'm Katie Moran McCabe with the Center for Public Health Law Research at Temple University's Beasley School of Law. And I'm really happy to have the opportunity to share a bit today about the legal response to COVID-19 in the United States. I want to thank the Network for Public Health Law for all of their effort in organizing this great event. So today I'm going to talk about Chapter 1 in the Assessing Legal Responses to COVID-19 report. I co-authored this chapter with some of my colleagues that are listed here on this slide. And this chapter provides a chronological overview of the federal, state, and local response to COVID-19 in the United States. Just a brief disclaimer that this presentation should not be considered legal advice, and any views or opinions expressed here are my own. So before we look at the chronology of the legal response, I wanted to just highlight a couple of the initial important dates related to COVID. So the first US case was confirmed by the CDC on January 21st. There is some dispute as to the exact date of the very first case in the United States, but the CDC confirmed the first case on January 21st. On March 11th, the World Health Organization then declared the outbreak a pandemic. Thereafter, there were several measures taken at the federal level, and there was a flurry of activity at the state and local level in response to COVID. So let's start by looking at the federal response. So this is a timeline showing some of the main actions taken at the federal level, along with the number of cases in the United States on those dates as reported by the WHO. So in January, the CDC implemented health screenings in a few airports for travelers coming from Wuhan, and the Department of Health and Human Services declared a public health emergency under the Public Health Service Act. In February, the Trump administration imposed travel restrictions on foreign nationals arriving from China in the beginning of the month. And then at the end of February, those restrictions were expanded to foreign nationals arriving from Iran. March was much busier as far as federal action, with the suspension of travel into the United States from many of the European states. Then the declaration of a national emergency in mid-March, followed by the announcement of social distancing guidelines, which were not mandatory, but suggested limiting gatherings and avoiding on-site dining. Also in March, emergency powers were invoked under the Defense Production Act, and US borders with Canada and Mexico were closed, and new legislation was signed, including the CARES Act, which we'll talk about briefly in just a minute. In April, we began to see guidance on reopening, with President Trump issuing federal guidelines for reopening on April 16th. Then in mid-May, the CDC released new guidelines for reopening, and the HEROES Act was passed by the House. In June, travel restrictions were lifted in many places, and the president restricted the issuance of visas that would allow immigrants to work in the United States. So this just gives you a sense of the timing of some of the main federal responses to COVID. And now we'll talk just briefly about a few of the details of some of these measures. So one of the main federal responses was the exercise of emergency powers, and those powers come from a variety of laws. The Public Health Service Act was invoked first, and this allows the Secretary of the Department of Health and Human Services to declare a public health emergency, as well as to make grants and activate certain funds. Then on March 13th, a national emergency was declared under the National Emergencies Act and the Stafford Act. And a national emergency, as opposed to a public health emergency, allows the president to activate certain presidential authority, including activating the National Guard. The national emergency that was declared in response to COVID freed up billions of dollars in federal funds for states and territories. It helped with allocating medical resources and also initiated the emergency powers of FEMA, the Federal Emergency Management Act. Then on March 18th, emergency powers were invoked under the Defense Production Act, which authorizes the federal government to allocate materials, services, and facilities as needed to assist in national defense. And I'll just highlight that Chapter 23 in the Assessing Legal Responses report goes into more detail about the Defense Production Act. So if you're interested in learning more about that, you can see that chapter. In addition to exercising powers under existing laws, there were also some new federal laws passed in response to COVID. So the Families First Coronavirus Response Act provided extended family medical leave and paid sick leave for employees who were unable to work if they had to care for a child whose daycare or school was closed. It also required smaller employers to provide paid sick leave for people who were unable to work due to seeking treatment for COVID symptoms or under a quarantine or isolation order. And then the CARES Act, as many of you may know, provided direct payments to eligible individuals, as well as provided funding for small business relief. It also expanded unemployment benefits and suspended student loan payments temporarily. So just as a quick recap, the main federal responses to COVID-19 consisted of travel restrictions, emergency appropriations and economic support acts, and social distancing guidelines, which again were suggestions but not requirements. So now let's take a look at what states have done. And before we dive into the overview of the state mitigation measures and chronology, I want to mention that most of the state level data included in our chapter comes from a legal data set that we built at the center. So we tracked COVID-19 emergency declarations and mitigation policies at the state level from January 20th through July 1st. We used a rapid policy surveillance process to create this legal data set and produce open source legal data that tracks changes in these orders during that time period across the 50 states and DC. We did use fewer quality control measures than we would for a typical policy surveillance data set in order to make the data available more quickly. So the data set includes legal citations, full text versions of the orders, and it was published with interactive maps like those that you see on this slide. The data can be queried by date and by variable. So for example, you can see which states had stay-at-home requirements in effect as of April 15th, and then which states had those requirements in effect on July 1st. And I want to highlight that we only coded explicit stay-at-home orders where there was a specific mandate that residents stay home except perhaps to do essential activities. And then we only removed the coding of those stay-at-home requirements where there was an order explicitly changing that mandate. So it no longer required people to stay home. And this data set, if you're interested in checking it out, this can be found on the lawatlas.org website. So here's a timeline showing the chronology of the first states to enact select measures in response to COVID, along with the number of US cases as of those dates. So just to highlight some of these, Washington was the first state to issue an emergency declaration at the end of February, also the first state to issue a gathering ban in mid-March. On March 19th in California, we saw the first statewide stay-at-home order. And in early April, Connecticut became the first state to have a statewide mask requirement. Then at the end of April, we start to see some movement to ease social distancing measures, with Alaska being the first state to lift its stay-at-home order in late April. Alaska was followed by other states that lifted stay-at-home orders. States also began reopening some businesses. But then after a spike of cases in late June, some states paused their reopening plans, even started closing businesses that had previously been reopened. And as you can see, at the end of June, Texas and Florida were the first states to mandate the closure of a business, in this case bars, after having previously reopened them. So here you can see the dates on which states issued emergency declarations. So I mentioned that Washington was the first to declare a statewide emergency at the end of February. And by March 16th, all 50 states and the District of Columbia had issued emergency declarations. This chart shows the dates on which states issued stay-at-home orders. So California, as I mentioned, was the first on March 19th. Many other states followed, issuing stay-at-home orders through April 7th. And as of July 1st, there were only 12 states that had not issued explicit statewide stay-at-home orders. In addition to emergency declarations and stay-at-home mandates, states issued other types of orders, including banning gatherings of certain sizes, closing non-essential businesses like retail stores, movie theaters, hair salons. There were orders mandating face mask use, imposing travel restrictions, and restrictions on elective medical procedures. So the charts on this slide give you a sense of the changes in legal response activity between mid-March and late June. So on March 15th, there were 14 jurisdictions that had taken some type of action, mostly imposing gathering bans, shown by the light blue color on the first chart there. Then by April 23rd, almost every state had issued some kind of order in response to COVID, with all but one state having required business closures and many states having imposed several types of restrictions by that time. Then by June 23rd, you can see the easing of restrictions across states, with many businesses being allowed to partially reopen, the lifting of many stay-at-home orders. But note the increase in face mask requirements. Those are shown in orange, closer to the center of the wheel. So we'll talk more about those in a few minutes. And if you look at our chapter in the report, you can see more of these charts showing snapshots of the legal measures at approximately 3-week intervals between March 15th and June 23rd. These are some of the other types of mitigation measures that states took: school closures, preemption of local regulation, meaning some states explicitly prohibited localities from imposing their own restrictions related to COVID. However, some states explicitly allowed localities to impose more restrictive requirements than those at the state level. And chapter 9 in the report is all about preemption, so you can take a look at that for a more detailed discussion on that. Some other state measures included moratoriums on eviction, foreclosure, utility, and/or water shutoffs. You can read more about those measures in chapter 25. And some states adopted policies for correctional facilities. And you can find more information on that topic in chapter 31. That discusses incarceration and the criminal legal system as related to COVID-19. So as I mentioned earlier, beginning in late April, states began to relax restrictions. After the White House issued guidelines for reopening in mid-April, states started developing their own reopening plans. And this chart shows the progression of states lifting stay-at-home orders, with the blue bars representing the total number of states that had lifted stay-at-home orders as of the dates shown along the bottom. So as I mentioned earlier, Alaska was the first state to lift its stay-at-home order on April 24th. And as of June 17th, 34 states had lifted their stay-at-home orders. And then the orange line shows the number of COVID-19 cases in the United States as of those same dates. So you can see that as the total number of states lifting stay-at-home orders increased, the numbers of cases were increasing also. States not only lifted stay-at-home orders, but as I mentioned, they also began allowing businesses to reopen at a limited capacity and with social distancing measures. And with the lifting of stay-at-home orders and reopening of businesses, states began requiring people to wear face masks in either in public places or while taking public transportation or visiting businesses. So by July 1st, 37 states and the District of Columbia had a face mask mandate. And so this map shows the different types of requirements that states had, whether it applied to the general public or just in business settings. Now let's take a look at the local response to COVID-19 in the United States. So most of the municipal level data included in our chapter comes from the National League of Cities Action Tracker, which is shown here. And the county level data reported in our chapter comes from the National Association of Counties data. And you can see here their map of county emergency declarations and mitigation policies. So the local level response to COVID-19 includes policies issued by municipalities and counties aimed at reducing the spread of the virus and mitigating economic impact on residents. And localities have taken many of the same measures as the states, issuing emergency declarations, stay-at-home orders, business closure orders, among others. So this is a timeline showing the chronology of some of the first cities to enact select measures. Just highlighting a few, Los Angeles and Honolulu were the first cities to issue emergency declarations on March 4th. In mid-March, Seattle was the first city to issue a moratorium on evictions. In early May, Memphis, Tennessee was one of the first cities to issue an order allowing some businesses to reopen. And then just as some states reopened businesses only to close them again, Boise, Idaho was the first city to do so on June 26th, closing bars after they had been reopened by the state. And here you can see the primary types of municipal policies that were issued in response to COVID. So again, this is based on data tracked by the National League of Cities. Most policies being aimed at preventing the spread, stay-at-home orders, gathering bans, business closures. And then other types of policies included emergency declarations, moratoriums on evictions or utility shutoffs. And then there were some policies providing emergency paid leave for workers who are not covered under federal protections. So, excuse me, if not preempted by the state, then local policies can be important because they may establish additional measures that are not required by the federal or state responses to COVID. So just a quick summary of the response at the federal level, mostly being comprised of travel restrictions, economic support acts, and social distancing guidelines. State level response involved mandatory social distancing requirements. And I want to highlight that there really was a high volume of activity at the state level, with more than 1,000 legal changes occurring as of July 1st. And again, these measures included not only mitigation requirements, but also orders easing restrictions, which were then followed in some states by new orders after a spike in cases, closing businesses that had previously been reopened. And then similarly, there were many response measures taken at the local level. So hopefully this gives you a sense of the various legal responses to COVID-19 in the United States. There will be much more to learn as the response continues to evolve. Just a reminder to please share your thoughts about the report using this hashtag COVID-19 Policy Playbook. And here's a link to where you can find the full report, COVID-19policyplaybook.org. List of our references for the chapter can be found on page 19 of the report. And I'd be happy to answer questions that anyone has. I'm going to see if I can pull up the chat box here and see if we have any questions that have come in. Just bear with me for a minute. So Sarah, it looks like I'm having trouble seeing the chat box. If you're able to help me out.
Sure, I can help
Thanks.
you. All right,
Thanks.
so the first we have it in 2 areas, so it's a little challenging.
Okay.
All right, so the first question is, how much preemption was there by states? Any way to measure that?
So yes, a couple of things, and I apologize, I'm getting an echo here. Hopefully you can all hear me okay. So in the data set that I mentioned on law.atlas.org, we did track which states specifically preempted localities from issuing their own restrictions, as well as which explicitly allowed localities to issue their own regulations. So you can definitely take a look at that, at the data set on our law.atlas.org website, and you can just query by the preemption question to see which states. I think at the high point, don't quote me on this, but I think there were about 20 states at one point that had preempted localities. And then again, if you're interested in learning more about preemption as it relates to COVID, I definitely recommend checking out Chapter 9 of the report.
Great. Another question is, were there more legal responses available at the federal level?
I'm sorry, the question is, were there more available at the federal level?
Were there more legal responses available at the federal level?
So that's a great question. I think and again, there are other chapters in the report that specifically talk about federal government response. I think that there may have been other opportunities for action. We, pulled out the main types of legal responses that were taken. Whether or not there were other opportunities, that's. I guess I would refer you to the other chapters in the report on that.
Oh, great. The next question is, have you can't understand that question. Have you been able to find a correlation between a certain legal action, such as mask wearing, with decreased cases?
So that's not something that we've specifically looked at. I mean, that is one of the big reasons that we created the legal data set, to actually create quantitative data that can then be compared to outcome data such as cases and deaths and things like that, to really see how effective these laws are and what their actual impacts are. We have not done that evaluation. We've sort of created the legal data in the hopes that researchers might do that evaluation. And again, there is, I believe it's chapter 2 in the report that does discuss the sort of research and evaluation of different measures that have been taken and what further research is needed.
Okay, great. Okay. Can you speak a bit about the impact the CDC eviction moratorium will have on local legal proceedings?
Um, I, I can't say what impact it will have. I mean, I think that's to be determined. Um, you know, it there certainly seems to be some sense. There's a couple of things with the moratorium. One, making sure that there's enough education out there so that tenants know what they need to do basically to qualify and to make that request of their landlord to halt eviction proceedings. Um, Related is the issue to what happens when the moratorium ends at the end of December. As of right now, there's no rental assistance that's in connection with the moratorium. So that remains to be seen. It's not necessarily halting or preventing evictions at this point, just sort of delaying them until after December 31st. So I think it remains to be seen what the impact will be. And part of that, I think, will be whether or not there's any rental assistance for tenants allocated during that time.
Okay, I think we may have time for one or two more questions. The next question I have is, have there been any constitutional challenges to states' actions in response to COVID-19?
There have, and I know there at least was one recent challenge to Pennsylvania's, several of Pennsylvania's orders, which is where we are. So there definitely, have been challenges challenges to gathering bans based on First Amendment, right to assembly, challenges to stay-at-home orders and business closures. So yes, and it's possible that there may be more as things continue to evolve. So we'll see what happens in Pennsylvania. I believe there's talk of an appeal, but that is definitely an interesting issue to watch when we're seeing so much action from the states.
All right, and then this is the last question. Can you speak about the enforcement of state and local orders? Any last thoughts?
So I think that's an excellent lead into the next presentation. That's not something, enforcement is not something that we captured in our research. So I can't really speak to the enforcement aspect, but I believe that our next speaker, who's talking about the Minnesota experience, is going to talk a little bit about enforcement. So I will punt that question.
And that concludes this session. And thank you so much, Katie, for your great presentation.
Thank you.
Thank you so much. Presentation slides will be available within a few days of this event. I would like to introduce Patricia Freeman, who will be speaking next.
Sarah, I can't seem to start my video here. It says that you stopped it.
Did I stop it? Okay. All right. How about now?
Okay, let me try now. Hopefully. Okay, there we go. Okay, I think you can all see my screen. I'm Patty Freeman. I'm legal counsel with the Minnesota Department of Health. I'm specifically located with infectious disease, and I've been working there for about 17 years. In 20 minutes or less, I'm going to try to give you a little portrait of COVID in Minnesota here. And so we'll get started. Just like Katie, again, I'm just my disclaimer for all you lawyers out there, you'll understand it. This is not legal advice. Those opinions are mine. They don't represent the Department of Health. The objectives, I just want to describe a little about the interaction between the different levels of government and also some specific legal issues encountered with these jurisdictions, including enforcement. Because I only have 20 minutes, I could spend 2 days on this, but I just picked a few areas. The first slide I just sort of wanted to show you, we started up in about February 29th, really working on this. If any of you know anything about incident command structure, that's what we started. We have situation reports, and we have every other day, we have meetings. We also stood up our emergency operations center. It's important if you are legal that if your state does have these meetings that you make sure you're included. Sometimes legal gets forgotten at the very beginning. If you want more information, you can get more information. I just wanted to give you a little demographics. Here's one slide. If you're interested in learning more about Minnesota's demographics, we do a great weekly report summary, and that will include information about disparities. And in Minnesota, there is definitely a health equity issue when it comes to COVID-19. And in that weekly report, there's some really good graphs showing the higher rates of cases in the African, Black American, Blacks, Hispanics, Native Americans. Okay, so our governor in Chapter 12 has emergency powers. What we had to do, I'm not going to read you this whole slide, but what we had to do is in beginning of March, the governor's like, I would like to declare a public health emergency so I can activate Chapter 12 powers and the National Guard and everything else that goes along with it. But in Minnesota, we don't have anything as a public health emergency. So we had to look at our statutes, and basically we decided that COVID was an act of nature. So we declared a peacetime emergency under act of nature. So we found a way to do that. The legislature, their powers is they have the power to terminate the state of emergency. Big power of theirs is the power of the purse, as you all know, is spending for federal and state funding. Our federal, everything has to go through our legislature, so they passed during regular session a quick bill saying that things could be done quickly. Truthfully, we're 85% federally funded in our infectious disease. We get no real state funds. In 2017, we did set up a contingency account for outbreaks, but it only was $5 million, which you can imagine was not enough for the COVID response. The Commissioner of Health is separate from our Commissioner of Human Services. I just wanted to make that clear because a lot of them states have those together. We are not a HIPAA entity, which is very important to know. Basically, the Commissioner of Health has taken all her actions through our general authority, and she has a number of different authorities. I just listed the two main ones that have to deal with collecting and investigating diseases. And then we have our communicable disease reporting rule, which all states, and COVID is reportable under that as a new disease. We also have local public health. So we have the governor, the legislature, the commissioner, and then local public health. We are a home rule state. But when it comes to disease investigation and infectious disease, the commissioner is sort of at the top of the pile or the heap. That's what it feels like these days, and helps direct local public health. Now, we have very good relationships with our local public health. There's 51 community health boards around the state, and we have good relationships and work cooperatively with them, but you can sort of see some of their powers there. And then another area that you need to be aware of is Indian tribes. We have 11 reservations. And as you know, with tribes, you have sovereign government. So state law doesn't apply to the tribal lands, except if you have like a tribal health clinic that's under the Indian Health Service, then they do follow state law. So I'm not going to give you a whole session here on Indian law, but it's very complicated. But all of our tribes did declare their own emergencies and actually have been doing pretty well and have pretty strict rules. So now I'm going to get into more as our governor declared an emergency on March 13th. What makes Minnesota maybe different than a lot of states is it's only good for 30 days. So he has to basically extend it. So we've had 4 special sessions because they've had to extend it 4 times because the 30 days was during the regular session. We have to notify the legislature, and there's also an executive council, which is made up of the Secretary of State, the governor, the attorney general, and lieutenant governor, and they're all Democratic, and they all have to approve the peacetime emergency, which they have. The legislature can terminate this peacetime emergency. So in the 4 special sessions we've had, the legislature has tried to terminate it, especially in the first 3 special sessions we had. But because Minnesota is one of the only, I think it's the only split legislature in the country, the House voted the Senate voted it to terminate it, and the House didn't go along with the Senate, so we're still in peacetime emergency. However, the Senate did not approve 2 commissioners of Commerce and Labor. So those commissioners were ousted. That is something that they could do even if they couldn't do the emergency. Okay, we've had 89 executive orders, which my understanding is a lot for a state. Minnesota provides some guidance. We work with other agencies to do that. And I'm going to get into my next slide. At the beginning of the pandemic, we were doing emergency orders without really working on guidance, jurisdiction, enforcement, without really thinking that through because everything was happening so quickly, which we ran into problems. So I really recommend that you think about enforcement, who has jurisdiction, and what kind of guidance you're going to give for each executive order before it's instituted, because before they declare it. Okay, so the governor declared this peacetime. Sorry, I went backwards here. Not used to doing these all. They tried to recall the governor for malfeasance. That didn't work. A lawsuit was also brought by 13 legislators and the Free Minnesota Small Business Coalition saying that he abused his power. However, on September 1st, the judge came back and said, nope, he's acting pursuant to his authority. It constitutes an act of nature. So our peacetime emergency is still in place. Some of the questions that are really important to ask are who has jurisdiction? For us, we have, is it the state? Is it the county? Is it the city? Or is there even someone else out there? Maybe a business, a school. Every state is going to be different, but those are questions to ask: who enforces executive orders, state or local police, licensing and regulating entities. I know in Minnesota and in other states, sometimes the local police have not wanted to enforce orders, and they've even said they won't enforce it. So with restaurants, the police have said, we don't want to go and we don't want to tell people that you're not wearing a mask, I'm going to fine you or take you to jail. So what the police have said is if a restaurant owner calls them and says someone is trespassing, and maybe they're trespassing because they aren't wearing a mask, then the local police would come and take the trespasser away. And then you have to think, how is it enforced? Again, the trespassing. And then tribal lands, because the state's executive orders aren't good on those. We have penalties for noncompliance. It's important to put those in the executive orders, or at least to know what those are, to know if you have any teeth to your executive orders. On June 5th, we safely reopened, and our governor really wanted to use the education mode, but did encourage state agencies and those with regulatory functions to really utilize those to gain compliance. And I'm going to talk about those with restaurants and bars in a few slides. Just thought I'd show you, on July 23rd, we found out about an Itasca rodeo. You can see the picture there. We talked with the owner, tried to ask him to take safety precautions. He was not too happy about that, and basically on his Facebook posting said, it's not a rodeo, it's a protest against the ridiculous government overreach. And as you probably are aware of the George Floyd, there were a lot of protests, and protests are treated differently than sort of a planned rodeo. We tried to think of options to stop it, but weren't able to. Again, you can see he has a sign saying rodeo entrance. You can see the people in the stands without masks. So our AG has brought legal action. And I'm just going to read a quote here. And this is in the Attorney General's complaint. Somebody who went on Facebook wrote, "It was great. Everyone just gave a donation and sat and watched the rodeo." So I'll leave you to decide whether it was a protest or a rodeo. It hasn't been resolved yet. Restaurants and bars are a big enforcement issue, I think, for every state. We so far, well, as of September 11th, received over 1,400 complaints. Those complaints are maybe people aren't wearing masks, too many people in the bar. Who enforces them depends on who has jurisdiction. The Department of Health has jurisdiction over some, and others are city and counties who they're delegated to do the inspection, to write up if somebody should be fined or write up a complaint. We really try to educate, so we try to go to a restaurant or bar, explain the situation, and hopefully they'll remedy it. But if not, they can be fined or there can even be a closure. In Minnesota, they've done 4 weekends of regional enforcement sweeps. They just go out. We don't say where we're going, but they go out to different areas around the state. Each week they pick a different area and just see how restaurants and bars are complying. We do this with other agencies, as is seen here. And they have found, I don't have the numbers here, but they have found people who were non-compliant and worked with them. I think a big area is case investigation, contact tracing, and privacy. This slide, sorry about this. I have my first virtual presentation and it's a little nerve-wracking. So this slide looks a little busy, and that's sort of the point, is we started out with our infectious disease staff doing investigations, and it got bigger and bigger and bigger. And that BCBS is the Blue Cross Blue Shield. They actually gave us 100 volunteers at the beginning. We're now up to 975 investigators. And what's important to know is you have to think about, you're going to have to make a contract with these, and what we're dealing with health information. In Minnesota, we have the Data Practices Act, which is actually more strict than HIPAA. And so we don't follow HIPAA at the state health department, but local public health might. So when we're working on these contracts, we have to be sure that we include information about following the Minnesota Data Practices Act, giving the Tennyson warning, which I'll go into in a second. And we now have even bigger is that Optum, we actually have contracted with an organization that's going to be managing all the case investigation and contact tracing, which means like setting people up, doing the training, everything. And they'll also be doing training and quality improvement. Well, one of the things they want to do is they want to record interviews. My understanding is in New York City that it's an opt-in. We have decided out of equity and fair that it's going to have an opt-out in New York City. We've decided in Minnesota that it's going to have to be an opt-in. So if a person is investigating a case and they're going to ask that person if, you know, someone can listen, they're going to ask them, will you allow us to listen? The Minnesota Data Practices Act, as I had mentioned before, is pretty strict, and most states have act or they follow HIPAA. So identifiable health data is private, and you can only release it with the consent of the person, to the healthcare provider, or commissioner's approval. And the commissioner's approval is something I think unique to Minnesota. We try to use it very sparingly and rarely, but if we need to release someone's name to do a contact tracing or to protect the health of the public from an imminent threat, the commissioner can give their approval to do that. Another piece is whenever we're collecting information, which includes case investigations, we have to give a Tennyson warning, and they have to, government entity has to provide certain information to the individual when collecting that information. And they have to tell them like what the purpose is and the consequences of not providing it and who we can share it with. So when you're looking at sharing case names for contact tracing, because sometimes we do have to do that if we have to figure out, especially if you're looking at long-term care, schools, corrections, you have to think about, you know, is it necessary? Because if you're not going to get consent, you have to go with the commissioner's order. You really want to be sure you need to do it. With whom? I'm sort of showing the congregate settings here, but you really want to share it with the minimal amount of people that is possible. For example, our schools have a COVID-19 coordinator, and that's who we would share something with if we had to share something. We have used the commissioner's order, for example, at the beginning, because there was a long-term care employee who did not want to share their name and they were planning to go back to work. So we needed to be able to notify the work not to allow that person to work, and also to do contact tracing to see who they were involved with. Another big area of ours was law enforcement asking governors to share case data. And we have a lot of issues there, and our governors, the law enforcement wanted it to be shared with 911 dispatchers. Some people didn't, like our legislators, but we had to address what issues, because it goes to the 911 dispatchers who then send it out to the first responders if somebody calls in for help. And there was a lot of issues to address, privacy and confidentiality. We had the 911 dispatchers and Department of Public Safety who were working with this information sign confidentiality agreements. There's logistics, technology, staffed resources. We also, basically, people were worried about what if I don't want my name sent. And so we also made it an opt-out, because the commissioner signed an executive order. And in that executive order, it said we had to follow the Minnesota Government Data Practices Act. And that required case consent to share, especially with our marginalized communities, our undocumented. They were very frightened, and we wanted to be sure and do our case investigations. But we set up a whole protocol, and I can tell you more about that. I just wanted to sort of tell you about that, and you can always contact me later for more information. There are some of the issues that we had. Legislators, some didn't want. We didn't want to give people a false sense of security. Again, we have the opt-out for disenfranchised communities. And I've just hit on a few issues, and this is very hard. I just wanted to show you some other issues, and I'm not really going to talk about them much, but you can also ask me questions about them or contact me afterwards. With child care centers, who is the enforcer? How do you enforce? We work with the Department of Human Services, because we're the ones who would recommend closure. Department of Education only has enforcement over public schools. So our private schools are actually under the executive order that businesses are under. So they have to follow the business rules on how many people you can have and masks. Long-term care, you have to get into who's going to conduct the test. Some of them don't have a medical director doing a standing order, getting consent. A big area for mass testing had to do with our food processing plants. They wanted us to give them the names of all the employees that tested positive. Well, we couldn't do that because of the Data Practices Act, and we said you have to get consent from your people. So there's all these different issues. And I have questions because there's just so many. I'm sure there are. But I did want to give you our website so that you could go to find that weekly report. We have a lot of other great information. We have them lauded on our website. And there is my contact information. I think I ran through this very, very quickly. So I'm going to turn it back over to Sarah to see if there are any questions. I hope at least you learned something in all of this.
Thank you so much for that great presentation. We are just waiting for some questions to come in. Can someone, you can all enter in your questions into the chat box in Pathable. I realize that some people have access to Zoom when we're asking questions there. But please please ask Patty some questions via the chat box on Pathable.
If you don't have questions, I go more into things.
You can go ahead, Patty.
Okay, so I'm just gonna, I can either go back to the data practices, or I guess one of the things that we're having problems with in Minnesota is, and this may be some other places, is private schools don't follow the same rules. And so they're even saying, you know, well, we don't require masking, or they're promoting that they don't require masking. And that's, I don't know how other states work, but I think it's important to figure out, and you have to work with your epidemiologists on really, you know, who's going to enforce it for those private schools. For public schools, the Department of Education has a lot of power there. And as I said, we look at it as businesses. So they could be fined like a business. But again, we try to focus on education. And you can tell me if a question comes up.
And we do have a question. Is there anything providers can do to get ready for the COVID vaccine?
Okay, well, they just came out today with all the, like, I think it's like a 25-page guidance on that. In Minnesota, actually, we're lucky right now. We're working with CDC on some planning. I don't know if there's a lot providers can do yet, and I think it'll depend on your state. You know, there are different vaccines have different, and this is not legal, have different temperatures. And so it's going to be interesting to, you know, think about temperature and storage. But legally, I think we just, you know, have to wait. We do know that pharmacists are going to be allowed, and some states allow pharmacists and some don't, but there's a preemption issue. In fact, we don't allow pharmacists to vaccinate certain children. And recently, just to talk about this, a PrEP Act came out allowing pharmacists to vaccinate children down to 3, which basically preempts our state law. But right now, I think everything is so new. I'm not sure legally if there's a lot you can get ready for yet.
The next question is, I would love to hear about the mass testing was organized and paid for in Minnesota. Who decided where testing was most needed? Were there any conflicts about how to distribute?
Oh boy, yeah, that's huge. I could spend, you can contact me more about that. One of the things we have with our ICS that I told you about, the incident command system, is really everybody is in their own lane, and we have a huge testing group, and I have worked with that. We actually have where those who are interested in testing can go in and request it into this testing group. So we've set up a whole system. For us, one of the bigs about mass testing was if you want insurance to pay, then you need a standing order because insurance won't pay without that. So we actually have our medical director who did a standing order. But a lot of times we try to find money, and then the state sort of stood up the testing centers, but it worked with, we have this whole testing group, and this is all they do is working on this issue. We had the National Guard train, and they were the ones who were doing the testing. But we do have contracts and worked with consent, and it's a very, to tell you the truth, a very complicated process. And most places that have wanted, with food processing plants, a lot of them worked with a local healthcare provider, or not health, like Sanford Health, to do their testing. But I think just having this huge testing group and having these meetings shows you really how logistically complicated it is. And we can go to our website and learn a little more about it. We do have a website on our COVID-19 page about testing, and I recommend that as a good resource. But you can also contact me afterwards.